Welcome to the Princeton Spine and Joint Center podcast. My name is Dr. Marco Funiciello, and I'm the co-director of the Interventional Spine Program here at Princeton Spine and Joint. I just had an amazing conversation with Dr. Rony Nazarian about both conservative approaches, that's minimally invasive approaches, and more conventional approaches for spine surgery. You may want to consider listening to this if you yourself need surgery, spine surgery, or you have a loved one that needs surgery. Dr. Nazarian is a board-certified, fellowship-trained spinal surgeon. He completed his medical degree at Albany Medical College, and then he completed his orthopedic residency at Albany Medical Center Hospital. He then completed a spine fellowship at the New England Baptist Hospital in Boston, Massachusetts. Dr. Nazarian is here today because he has extensive training in minimally invasive and conventional approaches to spine surgery. Thank you for listening. Welcome, Rony Nazarian. Pleasure to have you here on our podcast today. Today, we're going to be diving into a very important topic, one that I've gotten many questions about myself, and basically the whole concept behind minimally invasive surgery. And it's such a broad topic, and I figured who else to have here and discuss this than Dr. Nazarian himself, who does these procedures every day. So what exactly what does it mean when someone says is that surgery is minimally invasive?
Perfect question. First, let me say thank you for having me here today. It's a pleasure. I've listened to a bunch of these podcasts. Love them. These are wonderful. So it's really a pleasure to be here.
Yeah, awesome. Our pleasure.
So minimally invasive spine surgery. What is it? There's so much that goes into it. Before we can really fully talk about what minimally invasive spine surgery is, I think we almost have to backtrack to why we do surgery in the first place for the spine. Spine surgery treats a number of major disorders. We talk about things like disc herniations. We talk about stenosis, which is narrowing of the spinal canal. We talk about traumas, things of that sort. So one of the basic tenets of what spine surgery does is to try to treat the underlying condition. What I love about minimally invasive spine surgery is that it not only does that, but leaves behind the smallest footprint possible. Because we don't want the body to say, hey, why were you here doing all this work? We want it to say, thank you for what you did, more than anything. We want to leave behind as little irritation and injury to the body as possible.
So when we talk about minimally invasive, really you're comparing that to an open surgery, one that's going to leave behind more of a footprint, which I think is an interesting way to put it. I never really thought about it in that sense. So where do you often, in what kind of situations would there be perhaps an unknown whether or not you should go minimally invasive or if it should be an open surgery? Are there times when it's hard to determine between the two types of surgeries?
No question about it. We always want to try to do the least work possible in order to treat the underlying condition going on. I think one of the questions we have to ask ourselves as surgeons is, can we treat the problem at hand with a smaller surgery, with a minimally invasive approach, with smaller access, tubes, things of that sort? And some of it becomes a little bit of a gestalt. Some of it becomes what we're limited to because of technology and what we have available to us. But if we look at a patient's problem, we look at what's going on in their MRI, their clinical exam, their symptoms, and we say to ourselves, this is something that we can treat well with a minimally invasive approach. I'm confident that we can take care of this whole problem, the entire disc herniation, take care of all of the stenosis or the narrowing of the spinal canal. Then using a minimally invasive approach is the ideal way to do that. Now, if we look at the imaging, we say, God, the disease is just too bad. Stenosis is too severe. It requires too many levels of an operation that leads to more anesthesia. Then it's our job to be able to look at that and say, the risks don't necessarily outweigh the benefits. MIS surgery, or minimally invasive spine surgery, is great because it leaves that small footprint that I said behind. And I think I first thought about that, I heard about it in a lecture, and it just made sense, right? We talk about carbon footprints all the time. We talk about what we leave behind on the earth. And surgery is no different. We go into somebody's body to treat a disease process. but we have to get there somehow. And in order to do that, there could be some swelling, there could be muscles injury, there could be cutaneous nerves, there could be all these different structures that we have to go through that we would love not to have to cause any injury to. And minimally invasive surgery allows for that sometimes.
I saw a great advertisement, although probably unrealistic. I saw a huge billboard, minimally invasive surgery. You had a picture of a very athletic back with a little Band-Aid on it.
Yeah.
Now, realistically, I mean, minimally invasive surgery is still surgery. And when we say minimally invasive, I don't think that most people understand exactly what is happening. They don't have a good visual. They can't picture what that exactly means. So perhaps what are some common minimally invasive procedures that you would see in your office?
Sure. Minimally invasive surgery can include things like a discectomy, so a disc herniation into the lumbar spine or the cervical spine, where normally would be treated with an incision that's 1.5 inches or 2 inches, could be treated through a 3/4 of an inch incision. Mm-hmm. There's fusion techniques that can be done, something called a transforaminal interbody fusion, which is a fancy term for putting in screws in a cage in order to try to stabilize the spinal segment.
And you're saying that this can be done in a minimally invasive approach as well.
And you bring up a solid point. The surgery itself, so these are all terms that you've heard of before for conventional open surgery.
Sure.
The operation itself is really no different. It's how we get to the spine to do the surgery. So what we remove during a discectomy, same exact process. What we remove during a laminectomy to treat stenosis, same operation. Mm-hmm. But instead of doing it through a bigger incision that requires stripping of muscles and placing, strong retractors to give us visualization, we're able to do those things through small tubes and little micro incisions with the use of high magnification loops or a microscope that ultimately accomplishes the same goal. So the hardware that goes in for some patients, the actual work that happens inside the spinal canal, really no different between the two operations, with the exception of 1 or 2 type procedures. Over the last 5, 6, 7 years, there's a popularized procedure called the direct lateral interbody fusion, which is actually a great technique of helping people who've had prior surgeries in the past. Mm-hmm. And have developed more disease moving up their spine to try to treat it through a minimally invasive approach through the side of the body that requires much less work in the back with a much quicker recovery.
Are there times where you wish you could do a minimally invasive surgery, but just there's something about the structure, perhaps instability, where you know that you have to do an open procedure?
Absolutely. I would say one of the examples of that would be someone with very severe lumbar stenosis or stenosis in their low back. When we look at an MRI and we look at the severity of someone's symptoms, we can oftentimes tell that although we're doing the same operation, which is a laminectomy, the access or the space that we have to be able to visualize what's going on in the spinal canal is less with an MIS procedure. And the last thing that we want as a surgeon is to go in there and do an operation that doesn't fully relieve someone's symptoms. So as much as I would love for an elderly patient to be able to have a minimally invasive surgery, get them on their feet quicker, get them back home right away, same day surgery, sometimes I get the feeling that it's not going to relieve all their symptoms, and it's better to do it through a classic open approach.
And I do see that all the time, treating spines, trying to do physical therapy, injections, epidurals for someone who has multi-level, fairly severe spinal stenosis. I know that most likely if this patient does need lumbar surgery, if all the conservative measures fail, most likely they're going to need a multi-level fusion done. But I think it's exactly for that reason. You don't want to do a surgery and say, oh, didn't work, come back in for another one.
Right.
Are there times, though, that you would purposely go that route, try to do something minimally invasive, but knowing that there might be a high fail rate just because the alternative is so extensive? Do you ever kind of work in a stepwise approach?
For sure. An example of that I can think of is a condition called spondylolisthesis, or a slippage of a bone. Generally, whenever there's severe stenosis of the spinal canal related to that slippage, if we do a laminectomy, that causes more slippage of the bone and therefore would require a fusion operation. Sometimes we can consider an attempt of a minimally invasive decompression just taking the compression off the nerves on one side of the spine and leaving the rest of the structures intact in the hopes that we don't need to do a fusion operation. We know we have a plan B. We know that if the symptoms progress, we know that if the bone continues to slip, that we have a fail-safe, a secondary option that we will absolutely treat the patient's symptoms.
Gotcha. And in terms of trying to stay conservative with surgical approach, are there certain regions of the spine that lend themselves better to a minimally invasive approach? When we're talking specifically in the lumbar, the middle back, the thoracic, the cervical spine, the neck, is there an area where you see a higher percentage of patients with surgeries that can go minimally invasive in those regions?
Yeah, I would say the lumbar spine is really where we've made big strides over the last 5-10 years. With the advent of tubular spinal surgery, with minimally invasive screws, which are actually put in percutaneously through tiny little incisions, with the use of a microscope, with the advent of this new approach that we make from the side of the body with very small incisions. Minimally invasive spine surgery has come a long way for the lumbar spine. But it's true for, we can use it in other areas of the spine as well. And another common region is the back of the neck. Some patients may get what's called foraminal stenosis, or narrowing of a nerve that leaves the spine in the neck itself. Classically, we would do something called an ACDF, or a fusion and a decompression procedure from the front of the neck. Oftentimes, we can treat that through a small tube, just a little bit bigger than the size of a quarter, from the back of the neck to relieve that same compression of the nerves and get patients home the same day.
Now, normally, from my perspective, when I think about spine surgery, there are basically two situations in which surgery is more likely to be needed. And that is when there is compromise of the spinal cord or nerve root, where you have symptoms that extend into the leg, or perhaps numbness or weakness or loss of control. And the other is if there's instability of the spine. But many times patients have a spine issue just causing back pain. There's no radiating pain or sciatica or radiculopathy, as we call it. Is there any place for a minimally invasive approach to alleviate back pain? Are there procedures that exist for that, perhaps for discs or for other arthritic changes in the joints of the back?
That's a great question. We really need to go back to reasons for spine surgery, the indications for spine surgery. Generally, what we treat, I would say the huge majority of the time, are patients who have these radiating symptoms, like you talked about, that radiculopathy, pain, numbness, weakness down their extremities. There are patients who come in with really severe arthritis, maybe of one level of their back or one level of their neck. The first thing you always need to do, no matter what, and this is true of any spinal condition, is you go back to basics. You try anti-inflammatories, physical therapy. You try different types of injections. And those are the patients we send to you guys to use your skills for things like epidural injections or facet injections. I use their response to all these different treatment options to get an idea of, will they respond to a one-level procedure? So a back pain procedure is less predictable, but patients who have good results with injections like facet injections oftentimes can get good relief for their pain in the long term. And minimally invasive surgery can help in that scenario. So instead of doing a classic approach where we're making a 3-inch, 4-inch incision to do a decompression and put screws and rods in a cage in, we can do that through 3 tiny incisions that will get the same job done.
Gotcha. Is there a particular type of problem, particular type of pain that when you see this, you're like, I want to fix this. This is something, I got this. Just let me at it.
Yeah. I would say every problem, right? Because you want everyone to get better.
Sure. But there's some times when you see someone come in and you know what they have and how to fix it before they even say anything, just based on the way they're moving. And you know that if you do a treatment, if I do someone comes in and they have problems in their back where they have pain, where they're sitting for a while, they stand up and their back aches, and it takes them a while to extend their spine and stand up straight. And when I flex them backwards, they hurt. I know if I do a facet injection, they're going to be singing their way out of the office. Is there something that you see, like, if you let me at this, it's going to be awesome?
I would say 2 patients. And for both these patients, obviously, after they've exhausted all conservative means. But first, I would say, is the older patient who comes in, slumped over a walker or a cane, unable to stand upright, has to take 3 or 4 breaks from the waiting area just to get into the exam room, because every time they stand up to get this severe, terrible pain down their legs, there's a heaviness that they can't just take that next step.
You're talking about classic spinal stenosis.
Yes, yeah. Spinal stenosis. Yeah. It affects their quality of life so much. And what drives me nuts is when I see patients who have been sitting at home for 3-4 years with this problem. They've undergone all the conservative care they possibly could. And, their friends are calling them to come out, and they say, I can't make it all the way into the restaurant. I'm just going to stay home tonight. And I see them with this terrible 2-3 level spinal stenosis, this condition called neurogenic claudication, unable to walk. And I just know for certain that they're going to have a laminectomy, just a decompression of their spine, and they're going to feel 10 years younger, 20 years younger. So that for me, it's just hitting it out of the park. Yeah. I think another similar example would be a disc herniation. Young active people, even older active people, come in with this terrible pain down their legs, oftentimes associated with weakness and a foot drop. They have the altered gait pattern. They're lifting their legs in these weird ways to be able to get by. They've had anti-inflammatories, physical therapy. They've had injections and medicines, and they just, for some reason, can't seem to progress. Their body's not healing. Those are other people that are going to do so well. They're going to get back to that normal, active lifestyle again, which is great. Yeah. That's why we do this.
Absolutely. I got a side question on that. One thing you always worry about in a younger or any patient who has foot drop after, having acute disc herniation, foraminal stenosis, compressing the nerve, is will that function come back, or would they have a permanent foot drop? And I know it's a very complicated subject. We don't always know the answer. I mean, it depends on a lot of factors. But you've seen a lot of these foot drops, and you've seen people post-surgical. What are the trends that you've seen after doing a minimally invasive surgery? Someone who had weakness, foot drop, slap foot, and then having them have recovery, complete recovery versus partial versus no recovery. What's been the trend, and what kind of key things can you kind of predict what it's going to be like?
I can do one better. I've been on both sides of that table, actually.
Oh, yeah?
I was a second-year resident when I had a disc herniation, and I had a foot drop. I had a bad 3 out of 5 foot drop. I would walk, and my co-residents can hear me down the hall with my foot slapping on the ground as I'm walking. And then I've been on the other side of the table when I have a young patient who comes in with the same problem. And I think what I always keep in mind is progress. What I want to see is that they're responding to something. Maybe anti-inflammatories gets them so far, and then physical therapy gets them a little bit further. And then, oral steroid pack gets them a little bit further, or an epidural injection gets them the rest of the way. As long as you see that progress, that forward movement, the strength is getting a little bit better, the pain has gotten better, the numbness has gone away. That, for me, is what I need to see. And I am always happy to give it more time as long as we're seeing that forward progress. Right. It's when nothing is helping. It's when you get through each of these steps and the patient comes back and says, gosh, I'm no better than I was last week. That's a problem. And I don't want to see that kind of weakness with zero progress go on for more than 4 to 6 weeks. But it's controversial. Yeah. Some people say immediately need to take them to the operating room. I don't know if I agree with that from personal experience. I fortunately got better, with conservative care. And I think everyone needs to be afforded that option.
I think it's important that I've been blessed with having had a lot of injuries in my life that I've completely recovered from. But I'm blessed because I have a cervical disc herniation that I needed some injections for, and it completely recovered. But that's I think it's a blessing to have had the experience, and it makes you a better diagnostician, but it also you know what someone's going through. Of course, empathy is a big thing in medicine, of course.
It is. And listen, life's happening all at the same time as this disc herniation, right?
Nothing pauses.
Nothing pauses. So, if someone has a brand new job and they can't take 3 weeks off of work to get an operation, and they may take on the risk of waiting a little longer.
Yeah. And a lot of times it happens at work, or it happens when they're picking up their young children that they need to care for, and now they can't pick up. So
sure,
absolutely.
So I was a second-year resident. We just had our first child, and the last thing I was going to do was to get too aggressive and have to redo a whole year of residency. Yeah. My wife wouldn't want to have lived through that another year.
No, absolutely. So with more open surgeries, what would you say? I mean, in your practice, what kind of percentages are you seeing, just in general, across the practice, broad spectrum? Because you work with a lot of very talented surgeons. What are we seeing nowadays in terms of, at least in your patient population, in terms of having to go more open procedure versus minimally invasive?
I love minimally invasive spine surgery. I think what it does for patients with lower blood loss and less pain, quicker recovery, outpatient surgery is amazing. But with that being said, I would say my practice is maybe 30% minimally invasive. So not everyone's a perfect candidate for it. And
like we said before, you don't want to go into a surgery that you don't think will work.
Exactly.
It could work, but likely won't, and then have to have them come back in. Because even with minimally invasive, I imagine there's still scarring, and there's still the next surgery is still more complicated.
You were still there. Your footprint is still there. It's just smaller.
Yeah.
And revision surgery has added complications to it. So you really want to know that that patient you've picked for that operation is really going to get better. You want to be one and done. You want to treat that patient, have them go back to a regular life, and then to forget that they ever had an operation to begin with. And if an open, traditional, conventional operation is the right way to do that, then that's what you have to pick.
I just had a patient last week who underwent a microdiscectomy, minimally invasive procedure, and that was done a few years back, and he came in with the exact same symptoms that he had before. And we ordered an MRI, and it showed he had another herniation at that same level, and he was a bit thrown aback by it. And I explained that when you do this procedure, the whole disc isn't removed;
Right.
It's just the herniated fragment segment. But I was wondering if you can explain a bit about how often you see that. Is there anything done to try to prevent another herniation at that same level? And what are the risks that this will just end up herniating again sometime? And how do you prevent it from herniating? It's a lot, like 4-part question. Right?
Yeah, absolutely. All good parts.
Yeah.
So when I describe what a disc is to patients, I talk about almost like a rubber tire. Think about a tire on your car. And instead of air inside of it, you have the disc material. The outside of that tire is strong. It's this thick, solid material. And in the spine, that's called the annulus. And there has to be an injury to that annulus, a tear, an area of weakness, and that let a disc herniation come out. When we operate on the spine to relieve that disc herniation, we just take the damaged part, like you said. We don't take all the disc material out, because that disc still has a purpose. It has a job. It's a shock absorber. It's doing its thing, making sure the spine is functioning normally. But that tear in the outer part of the tire is still there. Now, it tries to heal itself. It scars over. It gets this fibrous material. But it will never be as strong as it was before it got injured. So out there, when you look at the literature, there's a high range of what chance of recurrence is. I think the accepted numbers are really about 5 to 7%. So it sounds like a really small number. But if you're one of those 5 to 7 people out of 100,
It's a big number to you.
It feels like a big number to you, right? Because no one wants to be part of that 5 to 7%. So a whole bunch of years ago, people started saying, well, what can we do to try to make this lower, try to make this reherniation rate lower? So for a while, they experimented with putting a stitch through this annular tear. Well, let's close it up. There's obviously an injury here. This is where the disc came out. Let's close it up so it doesn't happen again. And they found two things. First, they found that it wasn't changing the reherniation rate. Second, they were finding the complication rate was going up because these tears in this rubber tire, this annulus, are right in the vicinity of all the nerves. And then you have to stick this sharp needle around this tiny nerve in a very small corridor, and they found that they were just having more complications. So then you say, how do you change the patient's activities after surgery to try to keep it from coming back? And I tell people that's not the point of surgery. I don't want them to have an operation so I can wrap them up in bubble wrap and they can sit on their couch at home. They're getting this operation so they can go out and be active and live life. And if sometimes you're part of that 5 to 7%, you're living life getting there. And it's something that we treat and we manage and we get people back one way or another.
You see people who have these procedures and just in general minimally invasive and able to get back to 100% and in sports where there's cutting or jumping or just really lifting and more aggressive sports, more even contact sports. Are you seeing that?
Yeah, mean, it depends on what the operation is, but when we talk about smaller operations like a microdiscectomy, the idea is to get back to a normal life again. Even with bigger operations, you can.
Yeah.
So as a doctor, we kind of come up with these spiels, these ways of describing what our thought process is. And I have this spiel I give people about how they use their body with their activities. And I talk about buying a brand new car. Yeah. So let's say that you go out. What's your favorite car?
Probably for me, I really like the Teslas right now, but it won't work for me. So I just need more range. But
I understand.
SUV is my favorite type of car.
Okay. Let's say you go out tomorrow, you buy a brand new SUV. Yeah. It's gorgeous, it's shiny, it's new. Yeah. You have two options. You can drive that SUV to work and home every day. You live 1 mile away from work. 10 years, that car is going to look brand new. That SUV is going to be as new as it was the day you bought it, more or less. Driven it 2 miles a day. Now, Marco, I think you like going to the beach. I think we talked about that. You're a surfer, I think.
Yeah, I'm learning to surf, kiteboarding for sure.
Kiteboarding, yes. So now you can drive 100 miles a day to the beach. Yeah. You love going to the beach. You love kiteboarding. So every day you drive 100 miles to the beach and 100 miles back. 10 years, your car's not going to look so new anymore. It's going to be a little bit worn. It's going to be a little torn. And you can look at the car and say, well, why did I do this to my car? And you're going to look back and say, I went to the beach every day for 10 years. That was well worth it. That wear and tear is okay. That's what I tell people about their spines. Yeah. You're going to go and do more activity, more high-impact activities and sports. You're putting more wear and tear in your spine. That's okay if you're enjoying yourself. That's a give and take.
Yeah, and there's something that is was kind of beautiful about the human body that isn't as true about a car. Is you're absolutely right. Of course, if you're playing hard every day and you're really pushing your body, you're having a good time and you're really having experiences. And if you're not using your body, you're not using that car, you're not having the experience, you're not using your body, not having experience, but you're preserving perhaps from some injuries that you can have. But the beautiful thing about the human body is that it's probably better to use the body than not use it at all, because unlike a car, if you don't use it very much, it's not getting wear and tear. But the human body, it's a living organism. It needs to be used in order to keep the blood flowing right, to keep the vessels cleared, to keep our brain working properly, so to keep from gaining weight and all the negative effects that come from gaining weight. So point well taken. Yeah. But the beauty is that if you're going to err on one side, definitely go towards the side of more activity. Absolutely. Because the human vehicle will last less if you go too far to the low mileage side. Absolutely. Compared to the high mileage side.
So. You don't want to be the Tin Man either.
No, you do not. You do not want to be.
Yeah.
Yeah. Now, you have been you've been in Princeton for how long now?
Gosh, I've been here now for I think almost 9 years.
9 years. Yeah, I think it's the same time. I've been here. 2010.
Yes.
And you're over at Princeton Orthopaedics. And the surgeries that you see there, are you multiple hospitals or is it?
So we do. We have we're spread through the region now. We have a total of 6 offices spread out through Princeton, through down in Ewing. We're in Monroe. We're down in Robbinsville, and we help cover services at 3 different main hospital systems, including Princeton, Robert Wood Johnson, and Capital Health.
So the procedures that you do, are they done at any one of those hospitals?
Any one of those hospitals or at outpatient surgery centers.
Gotcha. And as far as I guess it's tough to ask a surgeon what their favorite surgery is. Is there one though that's your favorite, or is it all fun for you?
Yeah. Honestly, for me, my favorite procedure is the one where the patient wakes up and all their preoperative pain is gone.
Because that happens a lot with radicular pain. Yeah. I hear the story so many times. Someone has raging pain into a limb, and it's like, Doc, it was amazing. I woke up and it was gone.
It's this immediate gratification. Yeah. It's just I check on every patient through the recovery room about 45 minutes, an hour after surgery. And when you see them being wheeled back in this horrible pain, whatever transpires in the operating, whatever the operation happens to be, whether it's a decompression, if it's a fusion, if it's a disc, if it's whatever it is, right. When you see them in the recovery room pain-free, it's such a good feeling. It tells you, this is why you did this.
And of course, pain is subjective, but you see the look on their face. But one thing I would imagine is some people probably getting up a day or two later and they don't have foot drop anymore. It's like, that's very objective. So nice. You can see it. You can hear it from down the hall.
Absolutely. There was a young gentleman I operated on earlier today. He actually had a minimally invasive fusion, spinal fusion. He came limping into the hospital today. We ended up doing this transforaminal lumbar interbody fusion. And he's going home later today, and he feels better than he has in a year. It's such an incredible feeling to be able to do that for somebody.
Yeah, and you actually bring up a good point. Like, what are recovery times? What are we talking about when we say microdiscectomy, laminectomy, something small incision versus big incision? What are we talking about in terms of recovery time? Both in the hospital and afterwards.
Right. So minimally invasive fusion, most of those patients are going home in about 24 hours or less, or same day surgery. I usually give everyone an option. Some people respond to surgery differently. They wake up nauseous and uncomfortable and just not feeling quite themselves. And I wouldn't want them to go home and be in an unsafe environment in that scenario. But either minimally invasive fusion, same day or next day go home. Discectomies are all same day. One-level laminectomies are same day procedures. Oftentimes when we do multi-level operations that are open, we need to place a post-operative drain. It helps to clear any excess fluid after surgery. So those patients tend to stay in the hospital for about 2 nights or so. But everybody's up and walking the same day of surgery. And that's the key. I think that's one of the areas where we've come a long way in spine surgery. 20, 30 years ago, you'd have someone with sciatica and their doctors would tell them, just go lay in bed for the next month and you'll be okay. Or they'd have a back operation in the hospital. They'd be on bed rest for 2 weeks before they get up and get moving. Those days are long gone. We want everyone walking the same day of surgery. It's up and moving. It's that motion that really helps in people's recovery.
I had just recently had a patient come in with a significant back pain from previous sports, and then was lifting up a heavy golf bag awkwardly, twisting, and felt a movement in his back, and has clear-cut L5-S1 pain right down the back of the leg, sciatica. Let's say he goes in for surgery. He's home same day, next day. How long until someone like that can go back to work? I don't know if maybe it depends on how demanding, but just in general, back to work, back to playing golf. What are we talking about?
Desk job or a non-labor intensive job, they're back to work within 2 weeks. More of a labor intensive job, you're talking about more 4 to 6 weeks. If they have light duty, they can do something a little less. They can get back sooner. As far as golf and recreation goes, I usually tell people 4 to 6 weeks is a fair bet. It's not that you can't get back sooner, but we talk about that reherniation rate, 5 to 7%. We talk about that little tear in the outside of the rubber tire, that annulus that's still open and hasn't scarred in. A torquing force for playing tennis or golf, that can potentially push another little disc fragment out. So I try to hold people back about 4 to 6 weeks before they get into too strenuous of an activity.
And now let's say we have a more complicated patient, perhaps has a multi-level spinal stenosis. So you have that neurogenic claudication hunched forward in order to open up space for the spine, and you have to do a multi-level fusion, 2 or 3 level fusion, decompression fusion. What are we talking about before they can get back to work and they can get back to playing golf, perhaps?
Sure.
If they can,
right.
That'd be a.
They haven't been playing golf in a few years because of their spinal stenosis. They want to get back to it.
Yeah.
So they're in the hospital if it's a multi-level operation, a couple of nights, mostly because of that post-operative drain. Still getting up and walking right after surgery. I generally say they can get back to work for, again, a desk-type position, 4 to 6 weeks. So I'll extend it out another couple of weeks. Now, everybody's different. There's some people that are going to feel ready to go back in 2 weeks. There's going to be other people that don't feel ready to go back for 8 or 10 weeks. And we don't know who's who and why. Some people just respond differently to surgery. And we just have to, largely, give that personalized care. Just, wait to see, how they respond when they're really ready to go back. But certainly by 8 weeks, 10 weeks, almost everyone's back to a normal lifestyle. As far as golf goes, same time frame. Yeah. I'd like them to get a couple weeks of some rehab under their belt. If you really feel like their core is getting stronger, feel safe, and then they can start going back. But the key when people go back to these activities is not only being able to go, but slowly ramping up the activities. So, they're not going to go and play 18 holes the first day. They may just, go to the driving range and start swinging the club a little bit the first day and work their way up.
And I've had situations where patients were reluctant just based on research that they had done on their own, good old Google research, and that they wanted to. In their case, an open surgery was probably the right choice. Perhaps someone with multi-level spinal stenosis, but they'd gotten so many opinions from so many different surgeons, and there may have been a surgeon who was willing to give it a try to do a minimally invasive surgery and see what can be done. And in these cases, it's happened a few times. In these cases, they're worried about their functioning and how active they can be, and they're worried about putting hardware in and how that will limit them in their extracurricular sports activities. So are there limits that we see when we go one surgery versus another? Obviously, you have to restore the problem and fix the underlying issue, but are there restrictions that someone would have because they have hardware in their back?
I generally don't put any restrictions on people. After they're fully healed, I want them to get back to a normal, happy life. There has to be a sense of, I know I'm safe. I know that I can handle this activity. I certainly don't want someone who has had multiple operations, hip, knee, ankle, now they have their back fused, to go back to running long-distance marathons.
Sure.
I don't know that's the right thing for them to do in the long run. But with that being said, I don't have a problem with people getting back to the activities they feel like they can do safely. Again, they have to know what miles they're putting on their body.
Yeah, absolutely. But it sounds like in general, just because you're putting screws or plates or a cage in the back, it doesn't mean because you had to do an open surgery that now you can't be active.
Definitely not.
It's certainly stable, and it can take a little bit of a beating, but
right.
But within reason.
Within reason. The one exception maybe I can think of off the top of my head is people who have really severe osteoporosis. Their bones are just very fragile. They're brittle. And I'd be very concerned about that hardware being able to do its job while it's in there. Sure. But outside of that exception, I don't generally have a problem with it.
Very good. So we covered quite a few things. Is there anything in particular? You're seeing these surgeries, every day, every week. Any other things you think would be pertinent to any of our listeners?
I think that minimally invasive surgery, as amazing as it is, not everybody does every type of an operation. I think one of the most important things for a patient to remember is they need to have a comfort level with their surgeon, sense of trust in their surgeon. And I would not push somebody to do an operation minimally invasively just because it sounds better. It's the indications have to be there, going back to that one little thing called indications. Yeah. So I would always defer back to a surgeon's comfort on what the right surgery is and what they feel most comfortable doing, because most of us get to the same place. We just get there slightly differently.
And you're absolutely right. I can't tell you how many times I've had a patient, just because it sounded better to go minimally invasive, it doesn't mean it's the right choice for you.
Exactly correct.
You have to fix the underlying problem.
Right.
So,
right.
Awesome. Dr. Nazarian, thank you.
Thank you
for joining us, and thank you to all our viewers. We appreciate you listening to this podcast, and have a good day.